Hello, my name is Annegret Dahlmann-Noor. I'm a professor of pediatric ophthalmology, that literally just means children's eye health, at Moorfields Eye Hospital in London and University College London. I'm really happy that you are giving me the opportunity to talk today about one of my favorite topics, which is short-sightedness or myopia. Now, how is that relevant to you? Whilst I'm a children's eye doctor and my particular interest is in children's myopia and short-sightedness, the real motivation for me is that as an eye doctor, I'm very aware of late complications of short-sightedness or myopia, and in the main, myopic macular degeneration. Now, macular degeneration is something that brings us all together, and it is the commonest cause of blindness in the UK. But not that many people are aware of the fact that macular degeneration can also take other forms and can occur because of people having a high degree of short-sightedness or myopia. So today is an opportunity for me to talk about the older age spectrum, so middle-aged people like myself and over, who may suffer sight loss because they have been very short-sighted all their lives. And I want to briefly talk to you about what we know about this condition. Every good talk has to start with disclosures, and my disclosures are in the main because I am very involved in research with children and families of new treatments that are coming onto the market or that are being evaluated. And many of these are for short-sightedness and for lazy eye in children. And this research is often funded by pharmaceutical industries, and hence my disclosures on this slide for pharma companies such as Nevaka, Sun10, Sightglass Vision, Novartis, and Thea. And I've also contributed a lot to information events for eye care professionals, and they were in the main organized by Sun10, Cooper Vision, and Zeiss. As an overview of my talk, I basically want to talk about three areas. First, give you some background information about myopic macular degeneration, then talk about treatments that are currently available, and thirdly, talk briefly about current research. So if we start with background information, I think the real question is, why is MMD important? Now, that is not a question for you, because I know that many of you have suffered devastating complications from this condition. But you will also have found that your neighbors, optometrists, many people around you have never heard of MMD, and that even some ophthalmologists might think you have some sort of early onset age-related macular degeneration. But it is a condition in its own right, and it is affecting more and more people. And that is why I feel it is important to spread awareness and to tell people about it. So at the moment, we know that it is a major cause of sight impairment and even blindness in many people who have a high degree of myopia. So that is more than 6 diopters of short-sightedness in your spectacles or contact lenses. And we know that the risk increases exponentially the more short-sighted you are. So if you have 6 diopters of myopia, then your lifetime risk of suffering sight impairment by the age of 75 is about 39%. And if you're -9 or -12 diopters short-sighted, then the risk increases further. The other particularly important factor in my mind is that it tends to affect younger people than age-related macular degeneration. It can affect people of working age, typically late 20s to 60s. And that is a very important factor because people are still in work at that time and might not be able to maintain their job and provide for their family. And on top of it being a devastating personal event. There have been some studies of how common it is, particularly in the Netherlands, where a lot of very active and high-flying myopia research has been done over the last 10 to 15 years. There was a broad epidemiological study, so a study that involved people from all backgrounds of life. And they found, looking just at people who have a high level of myopia, that the prevalence of myopic macular degeneration was over 25%. That means that a quarter of people who had high myopia in that study also had some form of myopic macular degeneration. There has also been a study in France, but that looked at a hospital population. So that might be overall less informative because it is just people who have presented with a very severe form of the condition. So they found that the prevalence of macular complications in high myopia was 0.5%, but in very high myopia, so more than 10 diopters, it was 4%. And age 60 and over, there is a prevalence of blindness or vision impairment because of high myopia in 10% of people, and in people with very high myopia, 25%. So for me as an ophthalmologist, those figures are really staggering because we know, for example, about the prevalence of diabetes in the general population, which is around 4%. And we know about the prevalence of high blood pressure, but people don't really talk much about the prevalence of macular degeneration. So to see that it affects this many people is really quite heartbreaking. On the other side, we can use this information when we talk to funders, such as the NIHR and later on to the NHS as well, to make them realize that this is a very important area to look at and to support. When you look at the global estimates, the figures are even more staggering. Back in 2015, so that's 10 years ago, 10 million people worldwide were estimated to have a sight impairment from MMD. That's a prevalence of 0.13% of the global population. And 3 million were blind. That's 3 million people blind from myopic macular degeneration worldwide. That is staggering. And it was calculated that by 2050, if we don't find interventions that reduce the number of people with high myopia, then the visual impairment from MMD will grow to 55.7 million people, and 18 million of these will be blind. Then I wanted to briefly talk about the different forms of MMD, because many of you will be aware that in terms of treatments, we don't have very much to offer. And the treatments that are on offer are for very specific forms of MMD. So broadly speaking, there is a sort of generalized atrophy or degeneration of the layer underneath the retina. That's the choroid, which brings oxygen and nutrients to the retina. And then if that layer flattens and becomes insufficient, then the retina will suffer just because it doesn't get enough blood supply, nutrients, and oxygen. And in very severe cases, there can then be new blood vessels forming in the choroid, which grow through the lower layers of the retina, underneath the retina, and they can cause hemorrhages and thereby destroy a part of the retina. But the length of the eye, which is usually very much increased compared to people who are not short-sighted, can also develop complications. The length of the eye can cause the whole retina at the back of the eye to lift off. That is called a traction maculopathy because it's being pulled forward. Then there is a sign on our optical coherence tomography scans that many of you will have had, where the central part of the retina, the macula, assumes a dome shape and then doesn't work so well. And lastly, there are small little lesions that are thought to be cracks in the retina and the choroid that have to do with inflammatory changes that can happen in eyes that are very, very short-sighted. I've brought some pictures to illustrate these 5 forms. So on the left-hand side of this picture of this slide, there is a cross-section through an eyeball. And it shows you that at the back of the eye, there are several layers. The innermost layer is the retina, which changes the light signals into electrical signals. And the retina is the photosensitive layer, but it is hugely dependent on the layers underneath. So there is the choroid, as I already mentioned, that's like a sponge of blood vessels. And unfortunately, the more short-sighted you become, the flatter the choroid until it has become very, very thin. On the picture on the right-hand side, you can see the retina and the choroid in an optical coherence tomography scan. The retina is highlighted with purple lines, and the choroid is highlighted with the yellow vertical arrows. And you can see that it can be quite thick, 0.5 millimeter to 1 millimeter, in people who are not short-sighted. And the more short-sighted you become, the flatter the choroid, the less blood supply to the back of the eye. And the outermost layer that you can see on the schematic on the left, but not on the OCT scan on the right, is the sclera. The sclera is the white, tough outer layer of the eye. That is what holds our eyes together. And in short-sightedness, your eyeball grows longer and longer during the childhood and teenage years. And as it grows longer, the sclera becomes thinner, particularly at the back of the eye. And that makes the back part of the eye more unstable. And that can lead to movement or rattling, really, of the optic nerve fibers, which you again see on the schematic on the left. So the optic nerves collect all the information that is detected by the retina and takes it to the brain. And the optic nerve fibers need a solid support. So if your eyeball becomes very long, the sclera becomes very thin, then it's the support structure to the optic nerve that also suffers, and that can cause another type of sight loss because of myopia. But today we want to focus on the macular degeneration. So that is what happens and is visible on the OCT scan on the right. You can see the macula, which is the dip in the center of the retina, and you can see the underlying nutrient structure, which is the choroid. And if that becomes flat, then the whole choroid and the retina become atrophic, or very thin and flat and non-functioning. And this is what your optometrist or your ophthalmologist will see when they look into your eye and check the back of the eye. So this atrophy, this degeneration, can take different patterns. On the left-hand side, it shows a diffuse pattern. So there is one area that has just become very pale and very white. And that is an indication that the retina isn't working properly in this area. And that the reason is that the choroid underneath the blood supply layer has shriveled away. The rest of the retina would be working fine. That is the area that is orangey pinky. And the reason for that color is that there is so much blood supply going through the choroid underneath the retina. The middle picture shows patchy chorioretinal atrophy. You can see that there are big blobs of white area under the retina, and in all those areas the retina will not be working properly. And the picture on the right shows macular chorioretinal atrophy, where the white area is centered on the area between the optic nerve on the left of the picture and where the macula should be, right in the center of the picture. But instead of seeing a healthy macula with good red color indicating blood flow, it has become completely white. Then the second type of myopic macular degeneration is the neovascularization, which literally just means new blood vessels are forming. And on the schematics here on the left and on the right, you see how blood vessels can sprout from the choroid into the lower levels of the retina. And that in itself wouldn't be a problem, but these blood vessels are leaky, so they can leak fluid and they can bleed. And the photoreceptors in the retina, which are the cells that change light signals into electrical signals, tolerate that really, really badly. And then your central vision reduces. Now, this particular type of MMD is amenable to injection treatments with anti-VEGF medication, just the same as age-related macular degeneration. But different to ARMD, this happens many decades earlier in people with MMD. It can happen in their 50s, that they come to the point of having a benefit from having an injection, and they need less frequent injections. Many people only need 1 or 2 injections to shrivel these blood vessels away, and then they stay quiescent. Whereas in ARMD, you need to have regular injections for several years. This is what the new blood vessels look like on our OCT scans. So you can see here that there is this bulging mass underneath the retina. And these are new blood vessels that have sprouted through from the choroid underneath. And the same here. There is this lighter colored area, which is the new blood vessels. And down here on the third picture, just the same. The third type of MMD is myopic traction maculopathy. And what you see on this picture is that the retina, the layer at the back of the eye, has literally been pulled forward or has been split in alongside the different layers of the retina. So the inner retina has been pulled into the eye and is floating in front of the back of the eye. And that's bad news for the retina because it is separated from its underlying support and oxygen and nutrient supply. So it will stop working properly. Now, for this type of MMD, there is surgical treatment that will relax the retina and push it back onto the underlying structures. That may or may not then help with the vision, but it is at least an attempt to restore normal structure and normal vision again. And on the right-hand side of the slide, there is another picture showing the same. So there is this traction maculopathy. And in addition, you can see in the middle of the retina, there is a hole. So basically the two parts of the retina on the right and on the left of the central part of the eye have been pulled apart as well. So this is a macular hole in addition to a traction maculopathy. This is the fourth type, the dome shape. So instead of being completely flat, a flat layer at the back of the eye, there is this thinning of the choroid and the central part of the retina starts to bulge forward. And that, again, is not too good for retinal function. And the last form I mentioned, number 5, are these small lacquer cracks. These are little dark spots or white spots in the back of the eye that your optometrist or your ophthalmologist can see. And they might share that with you by showing you a photo of the back of your eyes. So it is thought that there are little cracks in the choroid and in the retina, and that there is some inflammation happening, and that then leads to scar tissue. And the scar tissue has got this white or black pigmented appearance. So in itself, that is not harmful unless it affects the central part of the retina and the macula. And these little lacquer cracks typically happen in people with high myopia. I will skip this slide, which is about the classification. So for us, one of the advances in MMD is that there has been an international group that has looked at lots of pictures and lots of case stories, and then came out with a classification of different stages of MMD, and that is helpful when you want to provide a better management. So we can then develop agreement on what treatment works best at what stage of the condition. But the individual steps and categories are the same as the ones that I have already talked about. And then the next question is if we talk about categories and treatments, do these things happen in a sequence? I think that is very important also for patients, or when you have a condition, you want to know, so I've got this now, how bad can it be? How bad can it become over time? So in lots of the children I see who have high myopia, the back of the eye has got a sort of tiger pattern appearance that is called tessellated fundus. But it literally just means that there are sort of blackish stripes shining through the retina. But in itself, it doesn't mean anything. Their vision is completely perfect. It's just the appearance of the retina when the eye becomes very short-sighted. So the question then is, can we predict who will develop MMD, and are there different stages? Well, we know that on the one side, if the eye becomes very, very long, then the back of the eye can start to begin this outpouching and the lacquer cracks, and this can then facilitate the new blood vessels sprouting through, and that can lead to atrophy. So to be aware of the sequence of events can help, because then you know what you need to watch out for over time. Then I want to briefly talk about the treatments for MMD. There are unfortunately still not very many, and they are only for very specific types of MMD. So when there are new blood vessels, I've already mentioned that people then benefit from having the anti-VEGF injections. We know that if we don't do anything, then 70% of eyes who initially have got a reasonably good level of visual acuity, that number of 70% goes down to about 55% after 3 years, and after 10 years, only 4% of eyes will still have good vision. So knowing that helps us make a decision that it would be beneficial to offer some treatment. And in the clinical trials that have tested anti-VEGF injections, they have observed a benefit in terms of gaining letters on the letter chart over 12 months from the first injection. And that was quite robust and sustained. So we offer these treatments on the NHS now. The traction maculopathy, we offer vitrectomy and buckling procedures. These are big retinal operations. And again, the reason being that it will at least stabilize the condition and in the best case scenario, even bring some vision back. At my end of the spectrum, I deal with children. So what I can contribute to the whole story is to make attempts at reducing the progression from a low level of short-sightedness to a high level. And the motivation is that we know that if we can keep the length of the eyeball at less than 26 millimeters, the lifetime risk of sight impairment is about 3.8%. If they reach 26 millimeters, it increases to 25%. And if the axial length of the eye increases to more than 30 millimeters, there is a 90% risk of vision loss in later life. So what we do is we try to use special glasses, special contact lenses, and atropine eye drops at the moment to keep this progression at bay. In East Asian countries, the problem is massive and is called an epidemic. In Taiwan and Singapore, more than 90% of boys age 18 have myopia. In the West, we are at the moment heading for about 50% in young adults. In the UK, the prevalence, the number of people who have this condition, who have myopia, has doubled over the past 50 years, and it's now affecting about 10 to 25% of children. The treatments that we have are to encourage them to spend more time outdoors, get more exposure to sunlight, spend less time indoors and looking at books and computer screens. And we have got atropine eye drops and special glasses and contact lenses. People from the myopic macular degeneration group in the Macular Society are particularly interested in red light-based treatment. This is based on trials that have been done in China and Taiwan, which showed that red light viewing for 3 minutes twice a day has got a very strong effect at reducing eye growth and elongation. Unfortunately, there have been some complications, and some children have suffered retinal burns and have lost some of their central vision. So at the moment, the jury is not quite out, and everybody in the UK is very, very scared of using red light treatment in children. So we are waiting for better research and more safety data at the moment. Our current research is looking for safer red light treatment. So my own group is working on red LED light, whereas the previous trials were done with red laser light. We hope that that will improve the blood flow in the choroid and therefore keep the retina going for longer, as well as reducing the elongation of the eye that is probably driven by the lack of oxygen at the back of the eye as you become more short-sighted. And that's my presentation for today. I hope that you find it useful, and I would be delighted to answer any questions. Thank you very much.
Annegret, thank you for joining us. That was a fantastic presentation. I know you're a real good friend to the Macular Society, so really thank you for joining us. I know that the MMD support group that meet once a month are very pleased that you're joining us as well. So thanks again. I do have a couple of questions for you. Sadly you can't join us on live, so we're doing a bit of a recording of these, so that's great. Okay, so why do you think there's been such an increase in myopia?
I think there is very little doubt that it's been driven by changes in lifestyle. So our children today spend less time outdoors and have less opportunity to spend time outdoors where they would be exposed to more sunshine, which has an inhibitory effect. So it reduces the elongation of the eye. And at the same time, with spending more time indoors, they look more at books and screens. It's also quite shocking for me to see how many children have their own smartphone, because with that comes a lot of time, so several hours a day, where they look at small screens and at a close distance. And all that tells the eyes that that is the distance that they should consider as normal, not looking in the distance, but looking at something at arm's length. And that is why the eyes become longer and elongate and come to the focal distance that is essentially our arm's length. And today, the numbers are shocking. I have read that over 90% of 12-year-olds have their own smartphone. But what I wasn't aware of until recently is that a quarter of 3 to 4-year-olds already have their own smartphone. So the content probably changes. The youngest ones look at cartoons and other entertainment things. And then as they get older, they grow into social media and into short clips like TikTok, etc., which are very addictive. So overall, it is the lifestyle with looking at something close up a lot during your time of growing up and the lack of time outdoors.
Good grief! It's it's a bit scary. It's quite a lot of young people with mobile phones these days, on them all the time, with their various social medias. So, what would you recommend for people with myopia who have some concerns around myopic MMD?
Unfortunately, there isn't an awful lot that you can do. So I'm myself about -4 diopters, short-sighted, and that confers a certain risk. But I've decided I'm not going to lose sleep over it, because at the moment, and at the moment, there is nothing that can be done about it. I think just general principles of good health are important. So spend some time exercising, eat a healthy and well-balanced diet. Try not to smoke. So basically do everything you can to keep your blood vessels healthy. And that's good for the brain, for the general body, and also for the eyes. But there isn't anything in particular that you can do to have a guarantee that nothing will go wrong with your eyes as you get older, whether it's MMD or age-related macular degeneration at the moment.
Yes, it's lifestyle, isn't it? Really. So leading on from that, then, so we know there isn't anything that can be done at the moment. So what research for MMD is around?
Well, at the moment, there is a study in Japan about using red light treatment. I don't think that there is anything else at the moment looking at the early stages and how to prevent it. I think that is what we are all keen about. So on the one side, you have prevention and how can we make it less likely to progress to a stage where you would have a sight impairment. And there we will learn more in the next few years about what can be done to maintain the choroid in a thicker state so we get a better blood supply to the back of the eye. And then at the other end, once you have suffered this scarring and atrophy of the retina, then we would need to look at completely different approaches. So that is where stem cell treatments, for example, will come in. But at the moment, the biggest efforts in that field have gone into age-related macular degeneration, and that still doesn't work for everybody. So I think we will just need to wait and see how that develops, and then hopefully with MMD we can tag on to all the insights gained from age-related macular degeneration and regenerative treatments.
Yeah, funny. My next question was about if you could repurpose research from AMD. So, what about gene therapies and things like that? Is there any scope for that?
Well, gene therapy is usually very specific to conditions where one protein isn't formed properly by a cell type in the retina, usually. That is not really the problem in ARMD and MMD because it's not a single gene defect. It's not a single protein problem. It's more this wear and tear and this wearing out and lack of oxygen and blood supply that happens over many, many decades. So I am not aware of anybody having found a gene that could be repaired and that thereby vision could be restored and retinal function. So I think it's less likely to be a gene therapy story than a stem cell treatment story.
Yeah, I remember Pete Kofi, sadly passed away
Yes.
recently. He did mention very much the same thing to the MMD group actually, that stem cells would be the way forward, and that would hopefully repair any of the damage, wouldn't it? So and then
There
I
is
suppose.
research going on. So I just briefly want to mention that as well. A colleague
Mm,
of mine at the Institute of Ophthalmology now has funding to build a model, if you want, a living model of the back of the eye, because at the moment we don't really know enough about the interplay between the retina and the choroid and the sclera. So having a model in the dish of different layers of different tissue, just like we have different tissues at the back of the eye, will be a very important tool to have, because then we can test possible treatments in the dish before we ever go to humans with that. But that is a very long-term approach. But that is something that's specifically happening because of MMD rather than ARMD.
yeah, it's very exciting. I think there's an awful lot of research around sight loss in general, which of course will cross the floor, so to speak, and cross into other conditions, which is brilliant. Well, Annegret, I don't have any other questions for you. So thanks again ever so much for joining us. I'm looking forward to hearing more about your research going forward, and I'm sure the MMD group will as well. So thank you ever so much for joining us today.
Thank you very much for having me.